Okay, good morning, everyone. I think we'll get started. Okay, so thank you for joining us today. My name is Samhar Zarat, and I'm the Acting Director for the Programs and Partnership Division at the Public Health Agency of Canada. C'est un honneur d'être ici à Londres avec les délégations venues à travers le Canada pour le 33e Congrès canadien de la recherche sur le VIH et SIDA. La plupart de cette session aujourd'hui sera en anglais. Si vous préférez entendre cette session en français, une traduction simultanée est offerte. Les écouteurs sont situés sur la table à l'arrière de la salle. So just to say that in English, the majority of the session will be in English today, but we do have simultaneous interpretation available. It's offered with headsets at the back of the room, so please feel free to grab some headsets. Okay, before we begin, I do want to acknowledge that Canada is the homeland of First Nations, Inuit, and Métis people. We all come from different parts of Canada, and I want to encourage everyone to think about the land on which you have the privilege to reside and work on. Okay, so it's been a pleasure for me to attend the conference this week and learn more about the amazing work that all of you are doing to advance research on HIV specifically, but STBBIs more broadly. I want to acknowledge the incredible leadership that's been displayed at this conference over the past few days. There's been many contributions from Indigenous researchers, community representatives, and people living with HIV. I've just really been impressed by everything that's happened since Friday. So the objective for today is really to provide an overview of the Government of Canada's renewed STBBI Action Plan. The action plan underscores the Government of Canada's commitment to reduce the impact of STBBIs and really improve the public health outcomes and advance the well-being of Canadians. The action plan, like much of the work that you are also doing, can only be achieved through collaboration. So I want to thank all of you for being here today, and it's through the conversations and collaborations that progress can occur. So I want to really recognize the pivotal work and the role that each of you play both here in Canada and abroad. Okay, so here is a little outline of how the symposium will go today. So I will first briefly outline the details of the newly released Government of Canada STBBI Action Plan, and then I do have my colleague here, Kristen, from CIHR, who will focus more specifically on the research priorities and actions that are in the action plan. And then from there, we're really looking forward to having a rich discussion from our panelists. They're going to be speaking about a specific action in the action plan, which is promoting comprehensive sexual health and well-being over the life course of individuals. One thing I will note is that at each of your tables, there is a summary of the action plan priorities. There is also a QR code on that page, which will give you rapid access to our action plan, which is available online. Okay, so a couple of policy documents that I would like to start off with. The first one is the Pan-Canadian STBBI Framework. Now, this framework was released in 2008, and it provides a common vision, guiding principles, and strategic goals to guide cohesive actions to address STBBI in Canada across all sectors. So this is a foundational document that was signed by the federal government as well as the provincial and territorial ministers back in 2018. There are three strategic goals of the framework. It's to reduce incidences of STBBIs, improve access to testing, treatment, and ongoing care and support, and of course, importantly, to reduce stigma and discrimination. So building on the framework, the federal government did create an action plan. There was a plan that went from 2019 to 2024. And then on February 27th, the Government of Canada did release a renewed STBBI Action Plan that goes until 2030. So the renewed plan identifies federal priorities and actions for implementing the elements that were first raised as part of the Pan-Canadian framework. It has 16 actions and 16 priorities and 49 actions. So you'll notice that both the framework and the action plan does take an integrated approach. That's something that's been mentioned a few times over the past few days. So it's an integrated approach around HIV, viral hepatitis, and other STIs. There is also, of course, a focus on key populations, and the aim of this action plan is to meet the World Health Organization targets by 2030. So it's really aligning everything towards those targets. As part of the action plan, there are 9 federal governments that are implicated, and you will see those 9 departments right on this slide. Each of these departments plays a particular role on the STBBI kind of platform. Of course, CIHR, as I mentioned before, will speak a little bit more specifically to the research components that are part of the action plan. For the Public Health Agency in particular, our role is to play a coordination approach in the renewal and the implementation of the action plan. So we do work closely with the other 8 federal departments to see how we can collaborate and really advance the work we want to do on STBBIs. So a little summary on the renewal process of the action plan. Last year, we consulted with many individuals via different formats, including an online survey, roundtable discussions, key informant interviews, and we did attend various STBBI events where we got a chance to meet with individuals. We did also share a full draft of the action plan to solicit feedback from that as well. So in total, we did receive 800 contributions from individuals across Canada, including key populations, healthcare professionals, members and representatives from community-based organizations, researchers, advocates, and activists. So on the next slide here, I do outline a little bit more detail on the 26 roundtables that we held. There were 7 regional roundtables that were held across the country, and these were held virtually. And we did have 6 thematic roundtables. Now, these roundtables looked at specific themes, for example, sexual and reproductive health and harm reduction, just to name a few. And we also had a series of 13 population-specific roundtables, and this did include people with a lived or living experience of HIV and hepatitis C. So I do want to acknowledge that these roundtables were co-led by STBBI leaders, and I see some of you in the room here who helped facilitate some of those discussions. So I really want to thank all of those who contributed to this renewal process. You very generously gave your time, your knowledge. Many of you shared personal stories as well. So I want to thank you for that, because it did shape the priorities and the actions that the Government of Canada has incorporated into the action plan. So what is new in this action plan? A lot of things. First off, the action plan is much more closely aligned to the framework that I mentioned that was released in 2018. Another key component that we heard about through the consultation process is that more specificity was required in the action plan. So we strived to incorporate some more detail and specific actions. So in the last action plan, there were 7 priorities, and now you will notice that there are 16 priorities alongside 49 actions. We also did identify some key indicators to see how we are meeting the 49 actions, and noted which federal department is implicated for each of the actions. A couple of other things that are new in this action plan is around the list of key populations. We did update it from the 2018 framework, and this is really based on input that we heard from stakeholders, and of course, the evolving epidemiology around STBBIs. There are some new categories that we've incorporated, as well as changed some of the wording for some of the existing key populations, just to make it more appropriate and reflect the feedback that we heard from individuals. Okay, there are a couple of boxes that we've highlighted in the action plan. I've pointed out 3 here for you that are related to sexual health, because that will be the discussion that we're going to have after this, but also around U=U and HIV, PEP, and PrEP. We do mention in the action plan sort of the effective, how HIV, PrEP, and PrEP are effective HIV prevention strategies. And lastly here, this gives you kind of an overview of the 16 priorities of the action plan. They are based on 4 key pillars, and these pillars are prevention, testing, initiation of care and treatment, and ongoing care and support. And all of this is supported by the foundation of the enabling environment. And that's where you're going to see a lot of things related to social determinants of health. So these are a lot of priorities. I don't think we'll have the time to go through all of them, but given that this is a research conference, I thought it would be particularly interesting to hear about the research-related priorities and actions. So now I'm going to turn it over to my colleague Kristen, who will go into more detail on CIHR's research-related priorities.
Thanks, Samhar. So I'm Kristen Kinderchuk. I'm a project manager with the Institute of Infection and Immunity, and we provide leadership to the CIHR HIV/AIDS and STBBI Research Initiative. So hopefully you're all familiar with CIHR and are aware that it's the Government of Canada's Health Research Investment Agency, so I don't need to spend much time there. Within CIHR, we do have a dedicated ring-fenced initiative that's the CIHR HIV/AIDS and STBBI Research Initiative, which receives $21 million per year to support research and training in priority areas related to HIV/AIDS and STBBI. And the funding here is always distributed across 4 research funding streams. This is a requirement of the original Treasury Board submission for the research initiative. So we're required to fund in biomedical and clinical research, health services and population health, community-based research, and to fund a CIHR HIV/AIDS and STBBI clinical trials research network. So in advance of the action plan renewal, the research initiative had actually conducted its own consultations leading to its strategic plan development, which was launched in 2022. And so as we worked on the renewal of the action plan, we were really able to align the actions that we took in our strategic plan with the new action plan. And in the past action plan, CIHR was sort of on its own island as a separate research initiative, and this time we've made efforts to really integrate with the plan as a whole. So as Samhar mentioned, the action plan is based on a foundation of an enabling environment, and so CIHR has made 3 commitments, or has made commitments to 3 of the priorities that were listed in the enabling environment. Specifically, we have committed actions towards fostering a cadre of First Nations, Inuit, Métis researchers by providing funding for training, mentorship, and other supports that enable long and productive careers. And we have committed to developing research and community-based funding opportunities to understand, address, and reduce the impacts of stigma, racism, homophobia, transphobia, sexism, and other forms of discrimination and systemically entrenched oppression. And so here I've just highlighted a few of the funding opportunities that we've actually released in the last year, and so the funding will be committed in the upcoming years that have contributed specifically on this slide towards the STBBI stigma-related priorities. So we had the Embracing Diversity to Achieve Precision and Health Equity, which had pools for STBBI, as well as an Indigenous STBBI pool. We revamped the community-based research program following a lot of feedback from our advisory board as well as input from peer review committees. And we had recently held an operating grant for addressing infectious and congenital syphilis that, again, had a specific Indigenous focus and community-based approach. The last priority within the enabling environment was to strengthen and support research capacity, and we made commitments to develop and invest in knowledge mobilization, to develop training initiatives that foster inter and transdisciplinary approaches, and to support HIV/AIDS and STBBI researchers across their journey. And again, I've highlighted some of the funding opportunities that we've launched that really support these areas. And I particularly want to highlight the CIHR Ready program, which helped to transition postdocs and research associates into faculty positions. And this was focused on providing support specifically to Black people as well as racialized women. And the STBBI Research Initiative specifically supported 10 awards for Black people and racialized women related to HIV/AIDS and STBBI. And the program as a whole supported 43 people. Towards the first pillar, which was prevention, we committed to building on sexual and reproductive health research to enhance the understanding of sex, gender, and sexuality and systemic barriers in shaping the experiences, risks, and outcomes of STBBI. We've committed to developing research and funding opportunities to advance the design, development, and implementation of the next generation of interventions, and to develop and invest in research and funding opportunities that address and contribute to the timely, culturally relevant, and effective responses to emerging and re-emerging infections spread through sexual contact. And again, some of the examples of actions that we've taken towards these commitments were the MPOX rapid research response, which we again had pools focused on key populations affected by HIV/AIDS and STBBI, the biomedical research team grants that were recently launched, which have a focus on, which have a pool specifically for prevention as well as next generation therapeutics. And again, the syphilis, which had been flagged to us by the community as a priority, and we rapidly tried to respond in concert with PHAC. That was a partnership with PHAC and ISC. And finally, we also committed to pillars 2 and 4 in terms of testing and ongoing care and support. With respect to testing, we have committed to invest in research and innovative technologies for testing and surveillance to better detect, characterize, and monitor STBBI. And we've also committed to develop and invest in funding opportunities focused on the implementation science research to better understand, define, and integrate the context, conditions, and adjustments that will maximize the uptake and adoption of new and existing testing modalities in different health, social, and cultural settings. So some of the funding opportunities we had committed to there, the Transforming Health and Integrated Care was really focused on implementation science. And again, the congenital syphilis funding opportunity had a strong implementation science focus. And the final commitments that we made were to facilitate opportunities to research, to develop, test, and advance culturally safe and holistic models of care and evidence-based interventions to achieve more equitable outcomes. So with that, I will turn it over to the panel discussion, which is going to focus on one of the priorities in the STBBI Action Plan, which is promoting comprehensive sexual health and well-being across the life course. So we're pleased to have such a great panel of esteemed researchers to speak to you to this today. And without further ado, I will turn it over to you, Jess.
Thank you. Thank you, everyone. It's wonderful to be here today with these fantastic panelists and to talk about one of the renewed STBBI action plans. Action plan priorities: promote comprehensive sexual health and well-being across the life course. Dr. Francisco Ibanez Carrasco, Dr. Randy Jackson, and Dr. Sian Wilson, thank you for being here today. My name is Jessica Wood. I am the Research and Project Development Lead at CCAN, which is the Sex Information and Education Council of Canada. CCAN is a national not-for-profit organization dedicated to the promotion of sexual and reproductive health. So we were excited to see the current priority in the action plan because promoting comprehensive sexual health through education is what CCAN does. We create sexual health education guidelines, benchmarks, and resources for professionals to implement one upstream approach to STBBI prevention. And like many community organizations, we rely on the critical work, guidance, and learnings from researchers and experts working in this area, such as the fantastic speakers that we have here today. So I'm very grateful and excited to hear from all of you. So to begin, I would just like to ask each of you to introduce yourselves briefly to the audience and tell us what projects or experiences bring you to the work of promoting comprehensive sexual health and well-being.
Started with me. Okay, thank you. Hello, everyone. And thank you for having me. I appreciate the invitation. I'm always hoping you won't regret it. And so I'm Latino, came in 1985, became HIV positive in 1986. So it's about 40 years of having sex in spite of all the guidelines. And it's been fantastic, I tell you. Think of your grandparents having sex and having fun. So that's one piece, that's a lived experience piece as a person living with HIV those years. Immigrant before EDIA was a thing, right? At that time, people would just tell you of things. And for some strange reason, they've accepted me at the Dalla Lana School of Public Health at the University of Toronto, and they allow me to teach young folks. I know. Who are mostly ethno-racialized, right? And it's an incredible opportunity which I treat with great respect. My research, I would have liked to have done research only on like PHAC and drugs and stuff like that. But when you come from the bottom, you have to do what other people tell you. So I've done a lot of research on cognitive disabilities, clearly, on health, physical rehabilitation, chronic pain now. I have a study in chronic pain. We give good money, send us your survey. And hey, you got to plug the product. And thanks to CIHR that believed in me as well. So, and now finally I'm getting a little bit inroad thanks to colleagues to work on needle exchange and work on harm reduction, which has always been of greatest interest, but you have to go where they tell you sometimes, right, to make your wobbly career. Thank you for the opportunity.
Thanks. Hi, everybody. I'm Randy Jackson. I identify as an Anishinaabe from Kittle and Stony Point First Nation. I'm also a person living with HIV, have been for, I think it's been about 34 years now. Yeah, so getting up there. So Anishinaabe, HIV positive. I'm also an associate professor in the School of Social Work with a cross appointment in health and aging at McMaster University. I've been involved in HIV research primarily for the since 1990, I think it was, or even a bit before that, and been involved probably on about 55, 56 research projects over that time frame. All of it, probably 99% of it was focused on Indigenous health, Indigenous HIV, and now, of course, we're expanding with, I co-lead the Feast Center for Indigenous STBI Research with Community Alliances and Networks. I see Claudette there. Yes, and so we co-lead this large center grant, which is really focused on how do we best use Indigenous knowledge in our STBBI research. So the grant's focus there, it's about helping and supporting not only community, but also scholars who want to incorporate some of these approaches into their research. I'm going to leave it there and pass it to my colleague, Cian.
Thanks so much. It's also so awesome just to share the stage with y'all, my esteemed colleagues. That just excited to be here and engage with you in some conversation. Cian Wilson. I am also a first-generation immigrant from the Caribbean, Jamaica specifically. Woo woo, always. Jamaicans are always, big up on Jamaica. And I've been doing this work for the last 15 years. I'm proudly a student of Sarah Flickers, who's in the room. And just wanted to hail that up because amazing keynote address. I've been doing this work for 15 years, primarily focused on the health, well-being, particularly the sexual and reproductive health of Black, Indigenous, racialized youth, 2S LGBTQ communities, and everybody in between, all of the intersections. That has been a lot of my work. I'm an associate professor in community psychology at Wilfrid Laurier University in Waterloo, Ontario. And again, amazing to share this space, and I can see some of my collaborators as well. So we're going to get into some conversations about some of the work that we've been collaborating on.
Awesome. Thank you all. It's so wonderful to have all of you here, and I kind of wish we had like a full half day just to talk with each of you about all of the fantastic projects you have. All right, Francisco, I'm going to ask you to get us started. So STBBI are often framed as a problem, heavily stigmatized, and efforts are positioned as preventing negative sexual health problems. But we know that comprehensive sexual health and well-being and promoting comprehensive sexual health and well-being is about more than just the absence of disease. And when we're discussing sexual health promotion efforts, can you tell us a little bit about why it's important to reframe our discussions to also include a focus on well-being?
All right. Thank you. I think that's our framing, right? Because the questions, I'm not demonizing anybody, but they come from above, right? And then we respond to the questions. So we use that kind of framework, but I think for other folk out in the street, they don't think of it as well-being. And of course, the kind of well-being that we as clinicians and researchers and peers and fuckers all around promote is very different. My well-being would be like being high on meth and having like great, messy sex in a group, right? And we're trying to do that actually in Toronto with the chemsex and empower the chemsex hosts. So well-being, a little bit bougie for me, right? It's like, what do you mean? That's our well-being, but I think the problem with this kind of document is how you translate that to the everyday practice. And the problems that I see with that is a boilerplate document, sorry, no offense, but you see a lot of these documents and people go along with it. There's no, I went to my team, that's called AI, because I have no team. I don't have that kind of money. So AI told me that the word pleasure is nowhere to be seen in the entire, you can look at it, right? That's one. Disability appears once. So we don't have people in wheelchairs who need surrogate sex workers, right? What the hell is that? And there was another third thing that I thought, digital things. For me, digital, when you say digital, it's all about pornography. It doesn't appear there. It's a huge industry, bigger than PHAC. They have more money than PHAC, and we continue to ignore them. While we understand, I was having breakfast this morning. I won't tell you with whom, but you know that choking, for example, is a thing among the young people. I mean, I didn't know that. I mean, we did choking when it wasn't trendy. You know what I'm talking about, right? Not choking with a piece of meat. Well, not that kind of piece of meat. I meant to just drop the phone. This is a drop the phone moment. Okay, so, and so those kids are alone on what they're doing, right? They're learning it from pornography, and it doesn't, how does this framework reach the health promoters, the outreach workers to really work with folks who are having fun, right? So for me, those are the main concerns about that and this use of well-being and our framing of it.
So thinking about well-being broadly and making sure that it includes the things
The
that people
mess.
need, and the things that are happening in their
And
their
pleasure.
reality.
Eventually,
Pleasure,
we all
yeah.
want to know on our own or with others, right? We want to have pleasure, right? We're hedonistic. Or am I the only one who's hedonistic? Yeah, I'm the other. Thank you. So no matter what culture you are, right? But how do we translate that in the everyday of nonprofits, clinicians, right? Clinicians talk to your people about using meth and having fun, that kind of stuff, right? Anyway, thank you for the question.
Thank you. Randy, I'm going to direct this next question to you. So, thinking about kind of well-being, absence of disease, can you share your perspective on the importance of a strength-based approach to promoting sexual health, and how have you adopted this approach within the Feast Center?
Well, yeah, it's a methodological approach that we adopted in Feast, a strength-based approach that we combine with Indigenous knowledge, decolonizing approaches, and CBR. So we approach our research using those three things. And what that means in practice is this idea of opening up a bit of space for us to think about sexual health and well-being in different kinds of ways than we typically do when we do that kind of research. I mean, we're all trained to sort of identify a problem, wrestle it to the ground, and come up with some solutions. And it's that always closes off the way in which we think about individual strengths. And we wanted to create a space where we allow that to emerge in the context of, really a lot of difficulties. And we know about those difficulties a lot when we talk about Indigenous peoples. We know what the problems are. So do we really need more research that focuses there? I probably don't want to focus my energies in that area anymore, so it's going to be about focusing on strengths. So when we do that, it interrupts sort of our pathologizing of Indigenous people. It opens up this space where we can address inequities by focusing on colonization, that kind of thing. It's more culturally relevant to be strength-based, and it's really about community empowerment and promoting resilience within those groups of people. So I'll leave it at that for now. Thanks.
Thank you. Cian, so we know that the programs and resources must be tailored to different communities to be most effective and address different and intersecting needs. Can you tell us how a community-based approach is central to comprehensive sexual health education services and research?
Yeah, so I'll give a scenario here just to sort of situate my response. A few years ago, we were funded by the OHTN to tailor an adaptation of a sexual health intervention from the American context with work with African American young people to African Caribbean and Black youth here in Ontario. And so, as you can imagine, we're changing contexts, we're also changing cultures, groups of folks with different histories to space place here in Ontario from the African American context. And so that requires its own sort of process. And that was done in partnership with organizations like the AIDS Committee of Cambridge, Kitchener, Waterloo and area, as well as ACDR, the AIDS Committee of Durham Region. I see Adrienne Betts over there and many others who are part of and parcel to that process. And so that's the context of this, of where, sort of these reflections come from. And so some of the things that came out of that work was just the importance of community-based research for the community members, community partners really drive the research. So in this particular project, we not only partnered with AIDS committee leads and executive directors, but youth programmers, youth leaders, pulled folks who were doing work with young African Caribbean and Black folks across Ontario into the process and into the project. And so really thinking about community partners and all of those constituents as knowledgeable equals in a process with skills and experiences that that are, equitable to your own. It's from a different lived experience, and it's as important to the formation of that project as well as, the process in order for that project to be impactful. And so really thinking about, those meaningful relationship building processes that are really integral to making this work transformative and impactful. I think impact is a really important part of when I think about CBR work, as well as just building on some of the things that Randy just said. That's really, really central to a lot of this work. Another part of this intervention adaptation, included actually having focused conversations with those stakeholders. So having focused conversations with the leads of ASOs, with the youth programmers, focused conversations with young people about what they're needing and where they see the barriers to sexual health intervention being. What are the barriers to adapting this thing to begin with, right? And so really learning from the ground, from these different partners, what the barriers and also the possibilities are. And so that was really, really central to the work and the approach. And I think that this, by and large, what also came out of this work is just the requirement of, investing in communities. So what I mean by that is hiring folks. So all of the youth programmers, all of our project facilitators came from community. They were either working at the partnering agencies or belonging to the African, Caribbean, and Black communities, or to us LGBTQ Black communities as well, making sure that you had the diverse representation within the communities that you're sort of working with who are a part of it, and using project funds to pay people. I think that's really, really important. And I really want to stress that if there's nothing else that you are going to do with project money, make sure you pay people. And that's super important. And I can proudly say I've never sent money back to a funder because I always make sure I pay people or top people, always make sure people are paid for the work that they're doing. And also mentor and encourage folks who want to, like for example, partner on writing or some sort of knowledge mobilization output, pulling them in to getting those experiences that they're asking for as well. And so there's a meaningful exchange, that there's like a reciprocal exchange going on in that research process is super, super important. Another point that I'll say is it's important that researchers understand, like I understand my role as a researcher to bring, the skills of methods or the skills of a particular approach to research, but understanding that doesn't mean that I dominate or I am the only person who's listened to or so on and so forth. I think it's one thing to say that we would be ignorant to say that power somehow in a community-based process is eliminated. It never is. That's the reality, right? However, what we can do as researchers is understand that we bring particular skills. There's also all of this rich wealth of experiences and other skills that if we respect and give space for can make that work so much more impactful. And so decentering our own privileges, decentering ourselves in the work is super important. Decentering our own hang-ups, our own defensiveness, our own egos, right? I think is super, super important. And then the last thing that's really come to mind from this work is that community engagement really increases the benefits of the work, the impacts of the project, and community members will be more engaged and invested in a process when they can see the benefits of the work. And so I've also seen that in other projects where community members take on leadership in projects when they can see the benefits and the impacts. And so you're doing a good job when community members want to take over and sort of lead the charge. And so those are just some of the things that I've come away from doing this kind of evidence-based intervention work around sexual and reproductive health that centers young people.
That's fantastic, thank you. And it really speaks to that, when you're talking about taking leadership and then, it's more impactful and you're working towards that systemic change and that long-term change that is led by the community. And
Absolutely, because what is this work for anyways? Is it not supposed to be impacting the systems that, we're working within? And who knows better what those systems are like except for the people on the front lines?
Exactly. That's wonderful, thank you. Randy, so we're going to talk a little bit more about tailoring programs to specific communities, and we know that they also require different research and program approaches. Can you share with us what holistic health approaches, land-based approaches, or empowerment-based approaches have been applied in the Feast Center projects?
Are we familiar with what land-based approaches are? I'm just going to maybe start there first. But for sure, I mean, when you center sort of research, when you start to incorporate Indigenous knowledges in research, what we found in the feast, and this is some of what we've been doing, and we've offered a few workshops now, a few land-based workshops where this has been quite good. But what we found here is that when you situate that kind of work on the land, it's also about a place where Indigenous people also go to heal and where they go to connect. And so you actually amplify that response within a research project. In other words, research can be more culturally relevant, and when it includes that, when it includes the land, it becomes much more culturally relevant. There's much more traditional knowledge that's driving the research project at that point. You focus on the well-being of people holistically to include physical, mental, emotional, and spiritual aspects of sexuality, and you center all of this in sort of ceremonies that promote sexual health and well-being on the land. So I'm going to leave it at that.
That's wonderful. Thank you. So talking a little bit about, the life course approach, which is the focus of this piece of the action plan. So the STBBI Action Plan emphasizes, the importance of comprehensive sexual health, across the life course. So I have a question about the impact, or talking about this with youth, and then talking about this with older adults. So young people, we know need different types of information and services, and CN, you have considerable experience working with youth. So what do you think needs to be considered when creating sexual health promotion activities and services for youth, especially for youth from equity-deserving communities?
Yeah, so here, after reviewing some of my own sort of overarching thoughts over the last 15 years, this is the bullet point. This is the note, the list. Okay, so the first thing is that young people wanted open, non-judgmental spaces where they can access free resources such as condoms, contraceptives, et cetera, information, et cetera. The other thing was that sexual health programs and services that actually engage as well as inform young people. So you want engagement as well as information. Youth wanted confidential, friendly, open, and geographically accessible sexual health services from a healthcare professional or healthcare professionals that they can trust. This was especially true for young people who lived in the GTA. And you might find that surprisingly because you might think GTA, lots of infrastructure, lots of supports, right? And that's not what I've seen anyways. And this is especially important with the pronounced sort of doctor shortage that we're also seeing, where people don't have a primary healthcare physician. We know that that's the issue is exacerbated for equity-deserving young people, especially Indigenous and Black young people. And so really thinking about how all of these issues are exacerbated, precariously housed young people. So again, primary care, in the absence of primary care providers, these support systems and health systems become all the more important. More clinical services in the under-resourced communities are needed. More generally, so youth have more opportunities to access vital services without outing their sexual activity or outing, who they're having sex with or the rest of it, or having to go to a family doctor who may disclose to your parent that, what you're up to. There was an identified need for holistic and culturally competent care to build on what Randy's already said. So services and resources, culturally competent and holistic care offered by diverse service providers who understand the complex and intersectional needs that these young people are facing, as well as a system and healthcare providers that push against the power dynamics inherent in sort of the existing healthcare system. So that was something that was really, really important. Is we also need diversity in our healthcare providers as well, who might have and resonate with some of our needs and the complexity of that. One model that's come up quite a bit in the work is community health center models, which show a lot of promise for our communities, as they may employ a more holistic model to healthcare, where you can go one-stop shop, see a physician, a nutritionist, a nurse, a social worker, a mental health care provider, harm reduction, all of it in one sort of geography or one location in a hub. That's shown a lot of promise. actually, access to culturally competent care for providers that were also diverse and reflected intersectional identities. So again, this idea of reflecting the diversity of the people in your catchment, which is super, super important. And so really thinking about holistic care in all of those different ways. And the last thing that I'll sort of name is the addressing that care needs to address, and I think it's often erased in these conversations, it needs to address anti-Black racism and Indigenous erasure as the foundation of the HIV crisis and STBBI crisis that we're seeing across the country, right? It's not enough to just talk about AIDS phobia or stigma without understanding the larger constructs of racism, classism, colonialism that sort of, I think, couch a lot of these conversations about whose bodies are considered risky to the public health of settler states, right? Who's outside of that? Who's the risk posed to when we think about public health, right? And so I think perturbing those conversations when it comes to everyone from, like, again, Black Indigenous folks to precariously housed folks to everyone in between and intersectionally identified. So really thinking about, I think, the complexity of that again, stigma is not where the conversation starts and ends, it's just where it begins. And if you dig deeper, there's larger systems and structures that we need to be considering to couch a lot of this conversation.
Oh, yes. Indeed. And it seems like that's often missing in a lot of training programs as well for, say, like healthcare providers or educators. Like that's something that we find often in our work too, when we're talking about sexual health education more broadly, is that those systems are often not addressed. And in terms of thinking about actually creating that systemic change, like that's what we do need to be having those conversations. So Francisco, we talked a little bit about youth and what the kind of needs that youth need to address comprehensive sexual health across the lifespan, or in their phase of life rather. But often, midlife and older adults, also need continued access to comprehensive sexual health education and services, but tend not to be the focus of ongoing programs and support, because youth may have access to education, say in school programs, and maybe there's more funding for community-based programs for youth. Can you just tell us a little bit about the importance of considering sexual health across the life course, including amongst older adults?
When you say older adults, you mean me?
Midlife and older adults. I mean, I'm also including myself in there too.
Well, I tell you, my lived experience, I think it's more interesting, my academic experience, is with the 40 plus. I'm a daddy. I didn't want to be a daddy. They made me a daddy. Shout out to the daddies in the, because that's actually a very important piece. Because it's an orphan generation. The 40 plus, wouldn't you say, Adrian, it's an orphan generation. And they didn't have sort of the everyday training in sexuality and how to deal with relationships and stuff like that. And they're kind of sandwiched between this new generation that is more sensitive to those things. They have less sex, according to King's Institute. And the old boomers were all sluts, right? So for me, that's a really interesting kind of heterogeneous group where we kind of forget to put some of our attention, right? And I'll tell you one thing. For example, I'm doing this research on chronic pain, and I think the problem is not so much, certainly nonprofits continue to do enormous work for no money, right? Strings, right? Yeah, I'm looking at it. That's right, like you count your pennies. I've been very steeped in nonprofit. So I'm talking to my team and I'm saying, okay, chronic pain, and I have wonderful clinicians, in alternative medicine, which wasn't a thing 30 years ago, but now it's been accepted. And then I go, well, how about that niche group? I know, but listen, people are kinkier than they used to be before, right? Yes, I'm looking at you, Abby. So how are we looking after their developing needs? Because people want to do what the gays used to do in the 1980s, right? How are we looking after them? And I said, what about people who seek to control their pain through pain? And one of my colleagues, we're on a Zoom call, fortunately, goes, that's disgusting. And I thought, so we're still there. We're still dealing with the disgust about the things we do, right? And for me, that clashes so hardly with this type of document, right? because more and more people are exploring their sexualities in full. This particular group in the 40s are kind of lost. They're doing it, but they're still kind of suffering, the AIDS specter, and they're too old to be trained and that kind of stuff. So for me, that is a group that requires a lot of attention, as well as youth. I mean, but that's not the people I work with, right? Thankfully, you could say.
Yeah, I mean, we need the requirements or we need the services and the approach across all different age groups, right? And people have different needs and require different supports.
People are learning stuff,
yeah,
right?
Exactly.
All kinds of stuff. That's what pornography has done for us. I mean, you learn and you're like, oh, I can do that. Well, no, you really can't, right? Like, you have to stop eating for like 2 days and take a lot of pills and stuff like that. You know that, right? I'm not telling you the behind the scenes. But we need to be aware of that, of the power of that piece of popular culture and how it moves people. In all respects, chronic pain, rehabilitation. I'm looking at Kira here, we work on exercise, right? We never ask about sex when we talk about exercise because, well, that's not exercise. It is exercise for me, right? I'm old, so I move one hand and it tires me out. So anyway, sorry.
No, that's great. Yeah, I think it's important that we're addressing sex and sexuality at different age groups, asking about sex, asking about pain at different points in our lives. I think it's an incredibly important piece, and because those things are always going to be impacted in different ways. So the next question is for all of you. So I've got kind of 2 more quick questions left that I'd like to hear from all of you about. What are some of the current challenges? I mean, we've kind of addressed some of them as you've gone through, the approaches you've used, the experiences you have, and, just the general kind of understandings of sexual health across the lifespan. But what are some of the current challenges in implementing programs and research relating to promoting sexual health and well-being across the life course? So maybe we'll start with Sian, we'll come down this way.
Yeah, sure. I'm actually working on a paper with one of my students on this exact issue, and some of the work that came out of that said intervention project, which is that really one of the biggest challenges is money. Like, we've got a current state of healthcare, and I'll speak about Ontario because that's what I know. I don't know the other provinces and what the state of healthcare in those provinces is. But in this province, we're watching the gutting of the public healthcare system, which drives those with resources to private sector. But those who are, who can't go to the private sector for a number of reasons, are reliant on the public sector, which is inadequate, right? And increasingly so because it's being gutted, it's being grossly under-resourced. These programs and this work requires funding to implement. I mean, surprise, surprise. And whether you're tailoring an intervention from a different context to this one or developing a new intervention, it requires money. And AIDS service organizations, as we know, are grossly underfunded. I believe there was a report that demonstrated that the AIDS service organizations staffing were the disparity between funding for this particular sector compared to other nonprofit sectors is gross. Like it's actually disturbing, right, in terms of the huge disparity between nonprofits at large and the AIDS service sector. So I just want to sort of highlight that as well as a really, really big issue, the gross underfunding of this sector. It's a huge issue, right? And so when you think about, what that then means in terms of the bandwidth for implementation and for these kinds of programming for different populations, I think you sort of see it in the wash, right? If you don't put the resources in, you're not going to get the sort of outcomes that you're hoping for. And with a gutted healthcare system and the over-reliance on nonprofits, I think it's just, a recipe for disaster, right? When we really think about it. And I think the other part of it is there's, utility in ready-made programs and the adaptation, but that also takes time. There's also utility in some of the programs that we've developed in-house with a lot of here, like, I know, for example, that AIDS Committee of Durham Region has, had developed a youth intervention in-house in the absence of other resources. So as much as we rely on evidence-based interventions, also recognizing the interventions that we've had to develop when there are no resources, when we don't have resources to adapt, and how we can, support those kinds of initiatives that are local as well. As evidence-based, which I think is important, but also, supporting local initiatives to do what we can with what we have. So I think it's not a if or, it's an if and. We could do both. And so I think that those are just some of the things that I think are the big challenge, money being central to a lot of that.
Yes, excellent, awesome, thank you.
Yeah, money, money, money. I had the same on my list of bullet points, but the one I want to focus on here, and I think we all know this from news reports that we hear around over time. I mean, and there are stories that, of course, I grew up with, but racism and stigma and discrimination are hugely and negatively impact Indigenous access to quality care. And this is something I think that needs to be addressed more fully. I mean, you just think of people like Joyce Ashquan who died in hospital because of racism. And I know a lot of other personal stories from different people across the country who've also had these experiences. So it becomes really important to, I think, to address some of that. Bridging, again, sort of these structural and organizational challenges like funding, it needs to also happen. Yeah, and I'm going to leave it there for now. Thanks.
Awesome, thank you.
Well, I think we can still have good sex without a whole lot of money. And I know where you come from. I get it, right? I get it. And so, you know, if you put your hands together, no, that's not. Anyway, So challenges, I still think we're dealing with challenges at the educational level. And this is not to demonize anyone, but one example that I confront, because I work with interprofessional teams, right, in which we look at new dentists, social workers, physiotherapists, we put them all in a room, and medical students, and the number of hours they get in terms of understanding sexualities, gender roles, gender is minimal still today in big universities, right? So they get like sometimes 2 hours, 1 day. It's kind of like crazy when you say it. It's like, really? So there is that piece that needs to be better. And of course, it needs the will of the faculties, right, of our colleagues who are sometimes very conservative, particularly if they're older. And it needs money as well to get more groups of students, because that is minimal. So I think that's key, right? We do what we can. I'm in a kind of a hippie area of public health and health promotion, and we're allowed to say a bunch of things, but it's interesting as you move up the ladder to your PhD. In a way, you're trying to do your work, what drives you, and at the same time you're being disciplined, right? So you have to behave certain ways and say certain things to get your money. So there's a constant passing, I would call it, without offending anyone, and double speaking that we are trained in. I think that's still a problem. It's very difficult, you know, not many people get invited to a thing like that and are able to, thank you for the invitation. Still, sometimes I'm like, wow, why they invited me, right? So we need more folks like that. We certainly need more vocal folks. We're talking about the reality, the everyday, right? Sex is cheap, trust me. Or my sex is cheap, sorry. I love it.
So we need more money. We need to work on figure out the structures and education.
For sure.
And
more sex.
And more sex. And I think there's also when we're thinking about like education, often there's a lack of prioritizing things around sexuality, sexual health. You know, and think about the education system in elementary, high school, and then in university, and then in medical training. There's often, it's not a priority to talk about sexual health more broadly.
Or is suppressed. I mean, let's talk with Sarah Flicker, right? And all the amazing work that she's done in that respect in Ontario. And, and then you go to the school level, Sarah, if I'm totally wrong, we're like, yeah, no, it's there, but we're not talking about that, right?
Yeah.
You're not going to teach that to my kids. So, and there's a huge backlash to it. I mean, I think it's mounting up, not smaller, sorry.
Oh yeah, that's one thing we talk about for a long time too, but we'll have to kind of wrap up in just another minute. But really quickly, but kind of before we wrap up, in a few words, can each of you just please state a wish that you have for the future of sexual health and well-being? So the action plan takes us from 2024 to 2030. If you have something that you think you would like to see happen in terms of education, services, research, and outcomes between now and 2030. So we'll go from this end down to the end.
Okay, oh, I want people to get their drugs and have fun and have money to do that. I mean, again, it's about money. But for real, like in nonprofits, then you have this lofty goals and they end up with like, oh, we have a little program. Oh, we're going to go into a bathhouse. Woohoo! Right? We're still at that stage, really, since the 80s. So that needs to be fortified. That needs money so people can do the thing, not feeling that they're begging you for money for something illicit, which is not, right? I mean, people still think that smoking cannabis and having sex is illicit. It's fucked up, right? And on the other hand, we have, let me just take a jab at this very quickly, you know, all these tools like, let's throw more condoms, and now we discover HIV test kits. Let's throw them, it'll save lives. Doesn't save paper, I tell you that much, right? Like the whole thing. And we have one test in Canada, like what kind of tool is that, right? And we end up, we're the land of pilots. We have one pilot after the other, and pilots are just that, right? Like a little show. Sorry, folks, my
It's
apologies.
all right.
No, yeah, no apologies.
Don't let me
needed.
go on.
Don't let you go. Yeah. I think for me, it's really about sort of the absence of some of the ways in which colonialism has shaped sexuality for Indigenous peoples. If you ended colonialism, what would sexuality look like? And if you dream about that for a bit, I think that that's a really powerful place to stand. Because you're reclaiming Indigenous knowledge at that point, you're decolonizing narratives around sexuality. You're empowering communities and providing spaces where self-determination is possible. These are combined with ceremony as well as a holistic approach. And I think that that's probably a better place to land. And the Feast Center has been working on this idea of Indigenous sexual futurisms. It's really centered there, bringing the past, present, and future together in one space in order to articulate what needs to happen. And I just want to sort of leave it here by saying that the Feast Center played a really small part in funding a project, the CBRC's Medicine Bundle Project. We funded just a little bit of what they did, and it was a really, really impactful project that is now hopefully going to go national, depending on a whole lot of things like refunding the HIV test kit, which needs to happen. I don't know why they would end that to begin with, but anyways, I'll leave it at that with that little advocacy point. And
Yeah. Thank you so much for that. I will just build on what my colleagues have already said, but I think for me, the one thing that I hope shifts and changes is that Black and Indigenous communities don't continue to be left behind when it comes to curbing the rates of STBBIs across Canada. This is a soapbox that I've been harping on in all of the committees that we sit on, as Francisco knows. That we don't leave these communities behind, and that we're doing so in processes that are also cognizant of the larger context of the ways in which poverty, racism, ongoing colonialism in the form of trafficking, and so on, how these things impact our communities differently. And so I think really thinking about that for me would be the sort of like takeaway as I look to the future and what my big hopes are.
Wonderful. Excellent. Thank you all so much. So I see we are kind of running low on time. We have 1 minute left on here. If there is maybe one question from the audience, and you want to come up to the microphone and state your name if you're from an organization, and if it's for all of the speakers or if there's one particular person you'd like to ask.
I don't think I have a question for a particular person, but I really want to think about like what is the focus on women in this framework? Like there's been such a dearth of attention towards women and STBBIs, and it has to get to the point that now we have congenital syphilis back before we even focus on women's sexual health. So it's like a woman's body doesn't matter unless it's birthing a child. So that's kind of the question. Within this framework, when are we going to get to that?
That's a great question.
Yeah.
That's a fair
Sian?
question. I should have probably also prefaced that the adaptation of this intervention that I spoke about was specifically focused on African, Caribbean, and Black young women. And there's also other work that I'm a part of with the CBRC that focuses on women's sexual and reproductive health as well, and particularly around STBBIs. So there is work, I think that is happening. I can see sort of the critique of that because I have seen the larger literature, which grossly over-focuses on men's health in the field and in the sector. But there are pockets where there are women's health, as well as non-binary folks' health also being centered, especially around youth, where our work focuses on women as well as 2S LGBTQ youth as well. So really important to be cognizant of that it is there.
Please. I'll try to be brief, but I might be lying. Adrian Betts from the AIDS Committee of Durham Region. The action plan is sort of upside down, and always has been for me. I'm a frontline agency, and in the last 7 months, we've had an influx of 310 new families living with HIV come in through refugees processes and asylum seekers and so forth from Ukraine, Brazil, Syria, Eritrea, Uganda, Nigeria, and we're overwhelmed. I've had 14 new kids join the HYPE program, our program for HIV-positive youth across Ontario. And so we're always trying to act in the moment. And yet the way the plan, the action plan is interpreted by the people who administer it restricts you. I can't pivot in the moment using PHAC funding to address specific issues. I had a HYPE summit in Blue Mountain 2 years ago. We did an MPOX clinic working with the local Department of Public Health. I got shit for doing medical work with PHAC money. I didn't use any of your money. I just happened to be there on a PHAC event, and I brought in these people to give 37 young gay men MPOX vaccines. I have an event I do every June, and I get $5,000 clawback this year because I pre-booked the place where we're holding this event. We have to pre-book, but no, the rules say you can't spend money this year. They never let the system go the other way, and research too the same way. I've been blessed to work with some wonderful people, Sian included, Mona Lufti, Jason Brophy, Carmen Logie, in terms of working with young people. But sometimes the questions asked aren't what we need you to ask. And so the more and more and more community-based research happens, and the more that researchers turn to frontline agencies asking, what do you need us to prove for you? Because if I can prove what I'm doing every day on the front lines and see those trends, and then I get the evidence to then maybe convince PHAC to actually help me address the issue that's happening in front of me. We talk about populations, but then when I say migrant farm workers, they're not included unless they're Black, right? If I talk about international students, well, we don't do that, right? They have their own coverage. Well, if you're a Saudi Arabian gay student and you want to access PrEP, you can't, because it ends up on your parents' information plan. And so they get HIV and they come to my agency afraid to go home because they might get beheaded. This is the sort of reality we deal with, and it just drives me nuts that the way this gets interpreted by the bureaucrats at Public Health Agency of Canada and then at the local public health level as well. It just constantly puts barriers in place of us making effective interventions that save lives. And so I don't mean to be mean and horrible and angry at everybody, but this session has been awesome. You guys are wonderful. I know you're champions for all of us. But like, anti-Black racism kills lives. It kills young Black people. It just does in the healthcare system. It kills Indigenous people. And we never say these things bluntly, right? And where are the homeless populations in these discussions, right? And as Abby said, women aren't just around childbirth. I'm sorry. I know I've said a lot, and I apologize.
So sorry, I just wanted to see if you, like, is there...
Is there a question?
Yeah.
Yeah.
Well, I mean, I just mean like we've got some
Yes.
people from PHAC who can note everything
The question
down.
is there going to be a concentrated effort from PHAC at some point to actually make systems that aren't so labor intensive and so rigid in their structure that people can't pivot to do immediate emergency frontline work? That's the question.
So none of the panelists are from PHAC, but I'm not sure if we want to speak about the need for flexibility in work. We also have maybe 1 minute left, but I know that the PHAC representatives are here to kind of note all of the comments down, unless there's anything left that the rest of you would like to comment on there.
Wholeheartedly agree with the need for flexibility. And when I think about Indigenous people and flexibility and programs, I think about how different Indigenous communities are across the country, and how what makes them different is their particular Indigenous knowledge and the land that they situate themselves on. And it's really important to pay attention to that. So one-size-fits-all projects or programs do not work in Indigenous contexts at all in any way, shape, or form. Don't do it.
And I think I would just add to that, like, I think what's being highlighted is also, in as much as it is for researchers to think about these things, it's also important for funders, the folks who are actually doling out cash, to also think about the ways in which communities have told you, we know what we need, just give us the money. And so making those, like, what would it look like to have funding calls that are available, that are really open for communities to describe the issues, the intersectional issues, the complexity of the issues, and that you're funding that. You're funding it based on what can be demonstrated as sort of a need. And so it would avoid some of the hoops that folks have to jump through, and the rigmarole that sort of Adrienne just sort of discussed in terms of the frustration. But what would that look like when funding calls are responsive to the needs that are emerging?
Yeah, the needs, and then you can be able to pivot in that time where you're speaking to the, the barriers that you face when you can't actually pivot based on those needs and the changing needs. So that's all the time that we have for today. I think we are incredibly grateful to all of you for being here. Thank you so much for sharing your time, energy, and expertise with everybody. And safe journeys home. Please enjoy the theater performance and the rest of the conference. And thank you all for your attentive listening.
Thank you.